And thank you all for joining us today. I'm Dr. Wilcox, the Community Coordinator at the New Jersey Healthcare Quality Institute. The Quality Institute is a nonprofit, multi-stakeholder advocate for the safety, quality, and affordability of healthcare for everyone. The Quality Institute oversees a statewide community health initiative called Conversation of Your Life, which is also known as COIL, and it's a program of our mayor's wellness campaign and generously supported in part by the Horizon Foundation for New Jersey. COIL aims to engage communities and residents in crucial advanced care planning conversations. We discuss topics like how to communicate your wishes to your loved ones and healthcare providers, hospice and palliative care, and the various advanced directive documents. Our programming is being adopted to various cultures and languages. Now, we don't know when a medical emergency or a public health crisis is going to occur. The COVID-19 pandemic has prompted many people to consider the advanced directives that they've been putting off, and we want to make sure that you have all the information and resources that you need to help you make decisions about the type of care that you want. We're going to continue to provide resources and have these crucial conversations remotely through digital resources, podcasts, and webinars like this one here today. Before I begin, I just want to go over a couple of housekeeping items. Please know that this webinar is being recorded and a copy will be posted to our website, www.njhcqy.org later today. All phone lines will be muted for the duration of the program to limit background noise. You may ask questions throughout the presentation and at the end of the presentation by typing into the chat box. And the topic for today's presentation is planning ahead for a medical emergency. What are my options? Please be advised it is not the intent of this program or its speakers to provide clinical or legal advice. So today we're honored to have Adrian, Allotey, Mindy and Jodi-Gail Duncan joining us for this presentation. After a brief introduction from our speakers, we will have a presentation followed by a Q&A session. So Adrian, whenever you're ready, you can go ahead and introduce yourself.
I'll introduce as part of, my work is an introduction for itself, so I don't want to waste the time for today, so don't worry about my introduction. If Mindy would like to say something as a co-presenter, her team, I would be, defer to them. If not, you can begin my presentation. Mindy, did you want to share anything?
You can start, it's fine.
Okay, sure. So why don't you bring up my presentation, please? So while he's doing that, I just want to start off by saying thank you to such an amazing organization for allowing me to speak on such a sensitive topic. And for you, the attendees, for showing up to begin this conversation. The dialogue is very, very important. So my name is Adrian Allotey, and I am a certified EndOfLife Doula. My company is called You Are Not Alone Elder Care. I established it because I wholeheartedly, honestly believe that everyone desires and is worthy of validation, and that each and every moment is equally valuable. People cherish and celebrate birth in so many ways. But what are the messages that we receive or even believe about end of life? The truth is, talking about end of life is a part of life. So today we are going to talk about the difference between an end of life doula, hospice, and palliative care. It's a question that I receive all the time. And so next slide. So I'll begin by asking you, are you living your best life today? As I shared, for me, each moment from birth to death is equally valuable. And that is the message that I bring to you today. Moments matter. This moment, this moment, this moment. They all matter. Next slide. So what do we do? Well, before I get there, let me just start off by saying that a Greek word that means, a doula is a Greek word that, excuse me one second. A doula is a Greek word that means a non-medical person that gives physical, emotional, and spiritual support to someone else. So how many people in our lives do we know that does that? They do it without getting paid. They're the ones that we call on when things are challenging. They just intuitively show up and provide that support. It doesn't have to be at the end of life. It doesn't have to be at the beginning of life. It's just every step of the way. So as it relates to an end-of-life doula, an end-of-life doula is a non-medical professional that provides holistic support for the dying and their loved ones before, during, and after death. We're trained in the various end-of-life stages and are able to assist the family with understanding the natural process while providing comfort and support. I specialize in the mental, emotional, and spiritual care of my clients. It is my job to actively listen. I listen to what their heart cries out for. I listen for things that are said and things that are not said. Next slide. So you may hear us being called by different names: death doula, death midwife, end-of-life guide. Although we all serve as a doula in the capacity I'm going to share, we bring different, sometimes secondary talents or skills. And so for myself, I'm also a Reiki practitioner. And as a Reiki practitioner, that involves healing around those who have that terminal diagnosis in their loved ones. All right, next slide. So what do? We provide support and care for those in the last phase of a life-limiting illness. We recognize dying as part of the normal process of living. And most importantly, we focus on quality of life for individuals and their family caregivers. Okay, next slide. Okay, so the Nhpco is a national organization that allows, excuse me one second, give me that. Is a national organization that that works with both hospice, palliative care organization, as well as end-of-life doulas. And so what their job is to provide information and resources to not only the hospice organizations and the palliative care organizations, but to also bring awareness and understanding of the role of the end-of-life doula. It educates to the benefits of doulas for dying people and their families, and it guides them on how to incorporate doulas into their existing services. And most importantly, it informs them on how they can access an outside doula provider. You know, I always tell my clients, when I go into a case, you have to have hospice on the case. Doulas do not provide the medical care at the end of life. The hospice team, and I'm quite sure that if Serenity Hospice wanted to add to it, they may have to add something to add, but the hospice team manages the care of the terminal patient. The hospice nurse teaches the loved ones how to do the care. But sometimes I find that once that hospice nurse leaves, the family, the patient, they forget what was said because of all the stress and anxiety around end of life. And then if their circumstance changes, they don't want to be a burden on the hospice team. So even though they have access to a 24-hour hotline, they don't want to call. So as a doula, I serve as the eyes and ears of the hospice team. Again, I cannot stress enough, the hospice nurse is the medical manager of the terminal patient. But with limited time at the bedside due to what? Medicare reimbursement guidelines. So yes, most, I wouldn't say if not all, but there are a couple cases where hospice is not paid by when you're dealing, if you're not on Medicare, but hospice is a paid Medicare, it's paid by Medicare. But when you're receiving Medicare funds, we all know that there will be guidelines. So the one thing I will say that both hospice and myself have in common is we believe in the whole person philosophy of care. We attend to the emotional, mental, and spiritual aspects of the patient and the caregiver. A doula is just simply an extra layer of support for the patients and the family. And we have no time limits, no restrictions. Again, we alert the hospice team to any changes in the patient. So that way the nurse can access and update the care plan for maximum daily comfort of the patient, which is really both of our goals. So, next slide. I have to say that EndOfLife Doulas fill in the gap for the medical end-of-life care team. Next slide. So as a doula, I listen to both my clients and to their families. And one of the things I hear most often is that they're not prepared. They're not prepared for that last breath. No one wants to talk about the last breath, but the reality is that we're all going to experience a last breath. Of course, unless there's no supernatural causes, and I have to be honest and say that I've seen it over and over again. When your life and documents are in order, there is freedom. You get to breathe again, and you have this space in your life to let creativity and enjoyment back into it. Not just your life, but the lives of your loved ones. So I want to just give you a few tips on how to prepare so that your wishes are known and there is no one questioning your desires. So what does being prepared look like? Decide who you want to make the decisions for you in case you are not able to make your own. Give serious thought as to how you want things to go once you're no longer here. And again, I can't stress it enough to contact a professional as soon as possible to help you with the needed documents, which we all know are called advance directives, just to ensure that your medical wishes are documented. Now, if that doesn't sound overwhelming, everyone, I want people to know too, that with being prepared, you can also go to your state health department, and there are documents on there that it's a template. And a template is better than having nothing. Okay, next slide. So I have to say though, I see a lot of people who pay attorneys and they pay a lot of money to get these advance directives in order. I guess how I differ from an attorney is I educate. I educate, so I don't follow a template. I educate on what the artificial life support measures are, what they look like, what's involved in the process, what are the pros and cons of each. I do not allow my clients to put away their advance directives in a drawer or under their bed. I facilitate family meetings so that everyone is aware of the wishes and on the same page. I ensure that the person chosen to be the healthcare proxy can actually honor those wishes. Sometimes, ladies and gentlemen, it's not the next of kin. Sometimes it isn't even the spouse. They just can't do it. So again, having these family meetings drastically cuts down on misunderstandings or disagreements later in life. People should contact a professional, someone like myself, sooner rather than later to do this amazing, empowering work. And I also meet with them annually to see if their wishes have changed. What someone wants at 30, 50, 80 can change. What someone wants at 79 and a half with a grandbaby on the way in 3 months can change too. I have seen people hold on just to see and hold their grandbaby for the first time. I also do what I create living well plans with my clients. I think it's important to document emotional, mental, and spiritual wishes for your last days, weeks of life. It's not just the medical stuff. It's, deciding what do you want that sacred environment to look like? Who do you want to be there? What do you want it to smell, feel like? Do you want to be touched? Do you want to be cuddled? Again, each family is really different. So the services really do range based on what the needs are. Also, who needs to be notified? Do you know that once you take your last breath, the body doesn't have to be whisked away? A lot of people don't know that. Some people want to create rituals. I really changed end of life from being like a medical event to being more of a human spiritual event. I even do dress rehearsals. Yep. Guess what? It cuts down on the fear of stress. And it also can bring humor, because when the things are actually happening, we dress rehearsal through it. Sometimes I'll hear adult children say, oh yeah, remember mom said this, and they're laughing about it. So all of a sudden the tears, there's an opportunity for some of those tears to be, humor. And so next slide, please. So if you don't walk away with anything, outside, the second message for today is be prepared, but you gotta know that there is non-medical assistance available. So what are some of the services? What does that look like? Vigil sitting. Once a person goes into the active dying phase, it could last hours, days. I've seen it last 2 weeks. And so everyone is different. People hold on for different reasons. And so again, like I said in the beginning, my job is to listen for what's said and not said. And with the spiritual aspect of what I bring, sometimes, and I bow down to the hospice nurses, sometimes there are non-medical reasons on why somebody is holding on. I also tell my clients, listen, this looks like it's gonna be a long night. Respite care. Go take some rest. Go downstairs. I promise you, if anything changes, I'll wake you up. And I do not, under no circumstance, want a person to believe that they are that illness. Absolutely not. Nor do I want their loved ones, when they come in there, to see the illness alone. So we do life reviews. We validate the purpose, all their life decisions, roles, contribution, impacts on their family, the community, and world. Sometimes people want to create remembrances, there's artifacts. Maybe they want to have cards that they send to their grandchildren or children every birthday. I help that as well. And so maybe it's a book. Maybe it's just a video. Maybe it's just a recording. Maybe it's a letter. And then again, people do not realize that the rights that they have once it comes to the end of life. So I do a lot of educating around that. Some people now, we are getting so creative, and some people like to even create their own service, write their own obituary. You have the right to and do that if that's your desire. And so as what's culturally appropriate, we can begin the memorial service planning if they're interested in that. Or I can help the family afterwards, because after you've dealt with a long illness, it's hard to go right from there to 8 o'clock to the funeral home in the morning. Okay, next slide. So what are the benefits to the terminal patient? Companionship, companionship, companionship. Just that emotional support and interaction. Early intervention. Something changes, get that nurse on the phone, let them make a change in the care. Everyone wants to stay independent. So increasing that sense of their independence. Nobody wants to give that up. Coping skills. Sometimes if there are family issues that haven't been dealt with, they'll show up at the bedside. So just helping facilitate those coping skills and making that family peace. Again, I get to stay longer and more frequent. Again, with those memorial arrangements, people can have a say-so on what they once said about them when they're no longer here. And just holding that space and the life review. You are not the illness. You are a culmination of each and every moment. And then again, you get to decide, is light important to me? Is candles important? Some people like that sacred environment of candles and all that good stuff and roses and different flowers. Some people want their grandchildren riding their little like choo-choo trains around their bed. They're okay with that. Some people want the football game on. Some people want to be spoken to, some people don't. So it's just creating what the sacred space looks like that for that person. Next slide. And what are the benefits to the family? You know, it's a lot of work being a caregiver. I don't take that lightly. So again, just providing that continuous support, answering those questions. Why is this happening? Okay, this is why, this is what normally happens. This is what we anticipate may happen next. Just being there almost on speed dial or next to the person saying, this is what's going on. And then just making sure that they understand the natural end of life. Again, they need breaks. They get tired. Training. When the hospice nurse leaves, what did you hear them say? You don't remember? Let's call them up. And then they also need to be held and comforted. And then, you know, again, like I said, making those memories, you know, advocating, letting them know that when that funeral home says be here at 8 o'clock in the morning, you can give it a day. You just dealt with a long illness. And then locating bereavement resources for them as well. All right, next slide. So palliative care. It's a specialized medical care for people living with a serious illness. It's focused on providing relief from the symptoms and the stress of the illness. The goal is to provide quality of life for both the patient and family. So you see the overlap in all three, right? The main difference is that the care team, the palliative care team is provided and is comprised of specially trained doctors, nurses, specialists. They all work together with the patient's doctor to provide an extra layer of support. It is appropriate at any age and any stage of illness. And palliative care, they're looking for curative, they're looking for treatment, whereas hospice care stops the treatment. And Mindy and her team can correct me if I'm wrong with that. The other thing I do as an end-of-life doula is I tell people, one, with your end-of-life directives, make sure your doctor understands and is going to support you in what your wishes are. And I also tell people, I mean, hospitals are amazing. They all are amazing. Our frontline workers are absolutely amazing. I usually tell people, find out the hospitals that have the palliative care though, because it's a different type of care. It's that same whole person care. So find out where those hospitals that have those departments are. You know, we're not all blessed to have them in every hospital. So if you have one and you have a choice in hospital, always tell them that. Can you hit that video for me for a second there? I just want to sum that up quickly. How's my time going? Okay, you know what? We won't go through the video. Let's just go to the next slide. So for today, I'm just gonna say, let's all just live. Don't worry about the video. You could put it in the comments. I don't want to waste time. I see the time is going by quickly. Let's just all live. Let's live. Next slide. And lastly, I just want to say, make moments count. Make a difference, make the call, make priorities, make the time, make your gifts known, make a nobody feel like a somebody, make your voice heard, make the small things big, make someone smile, make the change, make yourself a priority, make love, make up, make peace. Make sure you tell people they are loved. And you know what? Be so bold as to even make waves. Make sure you have no regrets and make sure that you're ready. And so that's the end. And then if you could be so kind, Mr. Wilcox, just to add that video, because I don't want to take too much time. And again, my name is Adrian Allotey. I am an end-of-life doula, and my company is You Are Not Alone Elder Care. And I apologize for the couple little tech things. And so I'm done with my part, sir.
Thank you for that. And up next, we have Mindy Fry and Jodi-Gail Duncan from Serenity Hospice. So whenever you're ready, you can share your screen and start your presentation.
Good afternoon, everyone. I am Mindy Fry. This is Jodi-Gail Duncan. I'm trying to get my screen to share. 1, 2. So here. There we go. Can you guys see everything?
Yep, everything's perfect.
All right, perfect. All right, like I said, we're with Serenity Hospice Care. Jody and I are a small part of a large team that comes together to take care of patients and our patients' families who come on hospice. Thank you, Adrian, for going over a lot of hospice services and care. It is true, hospice provides support and care for persons in their last phases of an incurable disease so that they may live as fully and comfortably as possible.
Hospice, hi everyone, Jody here. Hospice recognizes that the dying process is a part of the normal process of living, and it focuses on enhancing the quality of the remaining life. Hospice affirms life and neither hastens nor postpones death.
Hospice exists in the hope and belief that, like, throughout appropriate care and promotion of a caring community sensitive to their needs, that individuals and their families may be free to attain a degree of satisfaction in preparation for death.
Hospice offers palliative care for all individuals and their families without regard to age, gender, nationality, race, creed, sexual orientation, disability, diagnosis, availability of a primary caregiver, or ability to pay.
Now, a hospice does this by having an interdisciplinary team. A hospice interdisciplinary team is built up by our medical director, our case manager nurses, our social workers, our chaplains, our home health aides. We have volunteer coordinators. There's a lot of parts to an interdisciplinary team. It says here that it's nurses, social workers, chaplains, volunteers, music therapists, massage therapists, nurse practitioners, and the physician.
The hospice team works together to provide quality of care through development of a care plan that best addresses the patient's needs, ensuring quality of life and support to the patient, families, caregivers through the end-of-life process.
The hospice team will address logistical and emotional needs of patients, family members, and caregivers.
The hospice team will focus that in the final phase of a life-limiting illness, the patient's comfort and dignity are managed and respected.
These are some of our therapies. I did not have a photo of massage therapy, but we have music therapy. We have pet therapy. Actually, that little guy in the middle is mine. That's why he's front and center. That's Louie. The philosophy on comfort is a hospice staff works with the patient's physician to make sure that medications, therapies, and procedures are designed to achieve the goals outlined in the patient's care plan. The care plan is reviewed frequently to make sure any changes and new goals are in a plan for that patient.
Symptom management is key to a patient's overall comfort as he or she progresses through the end-of-life phases. Not only does the management of symptoms provide comfort to the patient, but also the family and caregivers. Hospice is about living, making each day filled with comfort and peace to be able to share special moments with the patients, families, and caregivers.
This is just a quote. Those who have the strength and the love to sit with a dying patient in the silence that goes beyond words will know that this moment is neither frightening nor painful, but a peaceful session of the functioning of the body. Serenity Hospice Care has been around for almost 10 years now. We're throughout the state of New Jersey. I put our YouTube station up here because I know right now, especially through the pandemic, if you are looking for music therapy, they cannot come in. Our music therapist did put together songs, to help promote their abilities, and also so patients can come together in a time when we're so separated. Jody, do you have anything to say on the social work side?
I am actually a social worker One of my main roles as part of the hospice team is providing not only the family and the family and the staff, but also, you know, the patient with decision making. Sort of what Adrian touched on: advanced directives, living wills, you know, palliative care, making sure that we are not only, you know, validating the family's needs, but also the patients, because essentially that's who we're there for. Another thing I wanted to touch on: hospice is not only covered by Medicare, but also Medicaid and some third-party insurances. So we, you know, we have a team behind the scenes that actually runs the insurance to make sure that the patient is eligible for hospice services. In addition to that, if we find that, you know, our patients don't have the insurance to cover it, we do speak with our administrator, and we accept some charity cases as well. Not everybody has insurance, right? Mm-hmm. Sometimes we come to this country, you know, we have patients that are here, unfortunately illegal, or their information expired, so that creates a lapse in coverage. You know, we do accept some charity care patients as well. Again, it's about the patient, the family, the team. You're welcome, Adrian. It's about the patient, the family, the team. We work collectively. If Adrian, for example, was to be the doula in the home with us, we would collaborate with her. We are a 24/7 service, so whether it be 3 o'clock in the morning or 3 o'clock in the afternoon, someone is available to take the phone calls and to answer questions. We do have nurses on call 24/7, so if there is a need in the middle of the night, the nurse can come out to the house to assist with care and to, like, you know, just provide that extra TLC that the family may need. I think, yeah. Any questions?
Yeah.
So if you could stop the screen share so all three of us are on camera, I have a couple of questions for our speakers. Let me switch this to gallery. So this is for anyone. I wanted to know, what specifically is advanced care planning and why is it so important right now, especially during a public health crisis?
So advanced care planning, I'm going to take that one. Advanced care planning is just ensuring that your affairs are in order, right? Whether it be, like Adrian put up on the slide, through a living will, a power of attorney. We can do a durable power of attorney or medical/financial power of attorney. There's also POST form. The state of New Jersey implemented this form. It's a green form. You find it mostly in hospitals. Some nursing facilities do have it. They're versed to it. The family and patients collectively are able to, you know, decide what their goals of comfort are. Like, what do they want at the end of life? I'll use myself for an example. I'm 35. I already sat down with an attorney. I have a living will, a durable power of attorney, meaning that's medical and financial. And I also have a last will and testament. It's different. A living will specifically talks about, like, what I want done in the event I become unable to make decisions for myself. And I'm able to list the person that I want in charge of my medical care. My power of attorney, durable power of attorney, because there's a difference, talks about the financial piece as well as the medical aspect, right? And then the last will and testament, that's just saying, in the event I pass, what assets do I leave to what person, basically. Adrian, anything to add?
Yeah, so thank you for that. I'm working with a family now, and and I'm telling them that not only is the health paperwork important, but also you got to think about the financial things. So I'm glad that you mentioned that. The only thing that I would add is that, so when you're like 17 and a half, your parents, all the way up until 18, your parents will make the decisions for you. I'm going to be so bold as to say that when you turn 18, that's when you should start putting things in writing. Now, again, they will change over time, but look what happened with COVID. And let me just tell you that our young people coming up, they're a little bit more open to talking about death and what they want. They have a clearer vision. I had a young lady who reached out to me in her 20s, and I was like kind of taken back, but she had an illness. She didn't know where the illness was going to go. She wasn't concerned about her last breath. she was concerned about her family. Can you help
Correct.
me facilitate this process? So, so hospice will step in if you don't have anything, but I say, don't wait until there's a problem. Get those wishes in writing. And as they change, you make the change. Don't just have a general policy and you put it out there and think it's gonna be good forever because your needs and wishes changes.
Right. And to piggyback off of that, it's essential to have, like, for example, the pandemic, like you said, we had young and old alike passing away from this unfortunate, thing, this unfortunate circumstance. And the families of the younger individuals and even the older ones had to, make the decisions. Well, what did they want at end of life? We don't know if they wanted hospice, if they wanted to not be resuscitated, or if they wanted to be intubated. There were so many questions left unanswered during this pandemic that we found that's why it's beneficial and it's important to have, so yeah.
Yeah. We could probably go on for an hour for that. I had another note, but I think you're absolutely right. What I saw with the COVID was that those who had COVID and those who did not, they all got swept away in that same river of care. And as much as, we were all learning and we all did our best, if the advance directives and the decisions you have to make are not like, okay, I'll get back to you tomorrow. They're like a decision. So you got to be ready and you got to understand what a person's desires are.
Oh, and that kind of leads to my next question. Jody was touching on various different types of advance directives, and Adrian, you also did during your presentation. I was wondering, where would I be able to go about getting one? And once I receive it, what do I do with it once it's all filled out? Where do I store it? Do I have to give it to my doctor? Do I hold on to it? What are the next steps?
So I actually went to an attorney to have mine drawn up. However, as a social worker with Serenity, we were able to go online and print out various advance directives. And in doing so, all we were asked the family to do was to have 2 witnesses. They would witness, and then we would have a traveling notar come to the house to notarize it, making it official, right? Because you can't go to an attorney in the event you couldn't go to an attorney. We would have a notar come to the house and notarize it. One would stay with the family. A copy would be given to the medical director or primary physician, and one would be left in the resident's house or patient's house. A part of our consent, we actually have what's called a do not resuscitate, DNR, and a DNH, do not hospitalize. If the family chooses to sign both forms, they're at those 2 particular pieces of paperwork are placed on the refrigerator. That way, God forbid, in the middle of the night, the patient passes, and the family, our natural reaction sometimes is to panic. So they panic and they call 911 before calling hospice. The EMTs come in and they would see the do not resuscitate, do not hospitalize. And then we would get a call, patient transitions peacefully, and our nurse would still go out to pronounce. Adrian?
I think that's important. Definitely do not store, right? Do not store, do not store. So like I said, not only do I create it, so I also, probably in my 30s too, had an attorney draw up all my documents. But now I realize that there's another way. So I felt like, it was a template. Do you want this? Do you want that? Yes or no? Whereas with the work that I do with people is we talk about, well, what does that look like? What does it mean? What does it mean to your body? What does it mean to your body at different ages and different stages of a disease? And then, so it's not like I feel like it's not so clear cut. So there are places where you can add like different scenarios. Like I said, things change over time. People are now getting very creative. They're videotaping themselves. And so you definitely want to have conversations. So you want to, the person you chose to be a proxy, you want to make sure that they know that they're a proxy. You want to have a backup. You want to make sure that they can honor your wishes. But most importantly, you want everybody to know, because everybody will hear something different. And that's when I facilitate the meetings, walking away. We all know. So that way at the end of life, it's not like the person with the loudest mouth gets to say so.
Right.
Oh, and we have a comment from one of our attendees. She mentioned that she promotes advanced care planning in Canada, and it's much easier for terminally ill that have the opportunity to plan and document as changes occur. She just watched a webinar that speaks to ensuring that your medical advanced care planning needs to be in medical language, as generic statements can easily be misunderstood by a medical care team. First responders will not take time to look through a home. Oh, that's very interesting. Thank you for pointing that. And moving on to the next question. So I wanted to know from your experiences, what are some of the biggest concerns that patients and families have when it comes to having these advanced care planning conversations? Because one of the main goals of COIL is that we have these conversations as early as possible, because when you're in a hospital setting and you possibly can no longer speak for yourself, it's far too late to start making all these important decisions about who your proxy is going to be, what type of care you would like. So I was wondering, what are some of these concerns to just having the conversation in the first place that you experience with patients or families?
So I would say that that's probably our biggest hurdle. Like, hospice is not used as often or as quickly as it should be used. People just don't like to talk about death, and more so maybe in, like, you know, in our country, they know it's going to happen, but they just don't want to talk about it. So it's just about really educating, and letting them see the change. I mean, I think that COVID has changed that some. It's really definitely a more death aware. We're definitely more death aware, but they just don't want to have those conversations. And so I would say that that's probably my biggest struggle. And so what I do is I just meet people where they are. And sometimes you have to give them a little bit at a time. Sometimes you got to come back, or sometimes, they're more open to talk about it once someone has just recently passed. So each one is really different, but they just don't want to go there. Most people just don't want to go there. So that's what I think I would say about that. Yeah.
So to add to that, I would also say that, one of our biggest challenges is having the family decide who the primary decision maker would be if the individual is unable to make the decisions for themselves, right? It's like, okay, so I have 3 daughters, and Mary Jane wants to be the primary healthcare representative. However, Mary Jane lives in Arkansas, for example, and I have my youngest daughter here, Sue, who, is a little bit irresponsible. So I'm choosing my middle child to be, my proxy. The 2 other siblings are like, well, why does she get to be the one? So that is what I find to be one of the challenges. And if the goals of treatment or the goals of care aren't in alignment with that of the patient, that can be challenging as well.
Yeah,
I'll say that.
I'm glad Jody brought that point up. So one of the things I do with my clients is, so I give everybody a job, because everybody can do something to add to mom or dad's care. So everybody gets a job. That way, whether they're in Arkansas or, they're around the corner, or they, work long hours, whatever it is, we all can be a part of her care. And so that sometimes can help with that problem.
You're right. That's a good suggestion. Yeah. Yeah.
All right. And I also just want to remind our attendees, if you have any questions for our speakers, please feel free to type them in the chat, and I'll get to them, as many as I can before the end of the presentation. And moving on, so I wanted to know what happens if you don't have a document prepared for you and you end up in a medical emergency or with a serious illness that leaves you unable to speak for yourself. What happens so what happens if you don't have that document that describes your final wishes?
So in my experience, the next of kin usually makes the decisions, being the spouse. If there is no spouse, the family. But again, because that's where one of our major challenges comes in, because if one sister wants mom to go peacefully and comfortably, and the other sister wants all aggressive treatments, it's kind of left up to the palliative care team to have the conversation more in depth with the families, and to say, okay, what are your goals here? What are you expecting? Mom is 97. She had a great life. Do we want her to go peacefully, or do we want to do all aggressive treatment? So it really depends on the family and like the cohesiveness in the family.
And let's not forget the role of the doctor, right? Sometimes they have to make quick decisions. And if you don't have those conversations with them, And that way they go in knowing that this is what's important to this particular person. Sometimes no one makes a decision in the family, the doctor makes the decision.
Right.
And for those of us in attendance that are considering having these conversations or completing their own advance directives, I've personally heard many times that people try to encourage their loved ones to complete their own advance directive, but they often find that they're met with resistance when trying to have these conversations. So I was wondering if you guys had any specific approaches or best practices that work as conversation starters for patients and their family members that you found they've responded to in a positive way.
So I try to tie it to an important event in their life. So if I know that you're at retirement, like let's plan this whole thing out here. Maybe you have a coming out, 60-year-old party if you waited that long, and that's part of it. And so part of the family meeting, I also, because I'm able to linger and hang out and all that good stuff, I create the family meeting around a theme. And so when they come to the table, there's a theme. So again, it could be like a 60-year-old, I'm coming out, I'm gonna take care of myself, I wanna be independent. Or the other thing too is that the reality is that no one really wants the adult child and the parent's role to change. So if you talk about autonomy, and what I find is that whether the adult children are extremely involved or not so much, there's this thing called guilt. And guilt is the same for every case. It doesn't get bigger, it's just plain guilt. And so if you talk about like things as far as minimizing that guilt, minimizing the burden, again, just it's about empowering them. Then they're more open, showing them that once you get this out of the way, you'll just feel better. You again, like I said, and it really does open up the space because both parties are worried about each other. So once you get that out of the way, it opens up the space for, like I said in the beginning, more creativity, more fun. It's just like, I got this, we got this. So it's a challenge. It's not that easy, but there are different things that I try to tie it to. And again, to try to make it more enjoyable. So we're doing it over wine and cheese or coffee and bagels, or, maybe watching a short film and then going into the conversation, those type of things.
So to piggyback on that, the pulse form that the state decided to implement, I've been finding that a lot of times when a resident, no matter how age, or patient, no matter how age, goes to the hospital, the care manager, the case managers, or the social workers do talk to them about the pulse form. Now, like I said, initially the pulse form, the state of New Jersey implemented this form. It's everything medical. There's nothing financial, but everything medical. So at least that's assists with the beginning of the conversations, because a lot of times when we go into the home, we can say, all right, do you have like a medical advance directive, or do you have what's called the pulse form? And the family will say, oh yeah, the social worker in the hospital gave me this form, and they'll hand it up and we'll go over it, we'll review it, and we'll make sure that, the patient's wishes are in line with what the pulse form says. It also comes in our consent packet, the pulse form. And again, if the family wants to take it a step further and talk about like a durable power of attorney or financial power of attorney, we are able to print those forms, get a notar out, have two witnesses, and to finalize that part of it as well.
Yeah, that's definitely good to know. I like what Donna put here. There are so many games out there. There are so many games to talk about in the life. I have like a bunch of them that I can just pull out. Sometimes I just pull out, we're having like these Zoom meetings with my friends. I pull out a card, we start talking about death. So I like that, I forgot that. And I also wanna talk about that post form, because if you find yourself under another doctor's care, that post form will follow you. So like with COVID, you went to a hospital, this is your hospital, your doctor's at the hospital, everybody knows you at the hospital, but guess what? People got redirected. Nobody knows the new hospital, but that post form will follow you. It's a doctor's order to say, this is what this person wants. These are the wishes. But Donna's absolutely right. The other thing I want to mention too is like there are deaf cafes now. So there are a lot of more people in the movement where the conversations are. I happen to facilitate like deaf over dinners where we just talk about death. Like, it's not a grief support group or any of that. We just get on the computer, now with Zoom, and we just talk about death. So look up death cafes, look up death over dinners. There are so many ways to have those conversations.
And the last question that I have for you guys, something I heard recently that's stuck with me for a while is the language around death is not universal. And the fact that we live in New Jersey, such a very diverse state in itself, I was wondering, how do you guys best address the topic of advanced care planning with patients of various religious and spiritual backgrounds?
So what I do is I take what's my vehicle to do that, because everybody should be honored for who they are. And a lot of times if like maybe a spiritual or religious belief is important to them, they will tell you. You don't have to ask. But how I prepare myself for those talks is I take chaplaincy classes. And so chaplaincy classes gives me an umbrella to learn about different cultures, different religions, and to be able to respect people for who they are and where they are. And they're not that expensive. So I'm able to add that skill to my plethora of skills, do chaplaincy courses.
Perfect.
To piggyback over that, so with hospice, because it is an interdisciplinary team, we do have chaplains on staff, and they're non-denominational. So if, as a social worker, I can't, that if the family expresses like a certain need or a specific need or request, I relay that to the team, and we work together to ensure that, the patient's wishes are, observed.
And the other thing I just want to add, because this is really important. So sometimes I'm called into rooms at the last minute. Nobody's there to tell me anything about the patient. What I do, and it never makes me feel good, but I know I'm going to get a big reward for myself doing the work as well as for the person who can't talk to themselves. I sometimes will open the top drawers of, not the second, not the third, but the top drawers. You'll find like the greeting cards. You'll find the cards that they receive throughout the year. So you'll learn, like, if they can't say for themselves, you'll learn that, this is their faith. You'll be able to call the names of the people on the card. And then if you read the room, sometimes there'll be things in the room that you can say, okay, I understand who this person is. But definitely, like, those cards that they've been receiving while they were sick, it tells a lot. So that's another little technique I use. And again, I never like to go through anybody's drawers. I was trained otherwise, but I know that there's going to be the special little things that they receive throughout the years, either hanging up on the walls or in those top drawers.
Thank you for that. And we are starting to run short on time. So I just want to let our audience members know, please feel free to continue sending in any questions, and I'll get to as many as possible before the end of this presentation. And I just wanted to say thank you all to our speakers for that information. And I just wanted to give a quick reminder that this webinar will be available later today on our COIL webpage, so that you can review the information that you may have missed, or you can share it with your family members and friends. We have plenty of other resources available for you too, such as our advanced care planning, preparing for the unexpected one-pager, where we've compiled trusted resources, all accessible from home, to help you and your loved ones start thinking about your wishes and strategies for how you can comfortably approach these important conversations with one another and your healthcare providers. We encourage you to take a look at this document and share it with your family and friends, and stay tuned, because COIL will continue to push out resources such as one-pagers, webinars, and digital podcasts for residents and healthcare providers. So
thank you for the service that you do. So you're also helping us do our work as well. That education.
Of course.
Definitely.
Absolutely.
And thank you, Serenity, as well. I learned a couple new things, so I appreciate that. And again, I always say,
you're welcome.
You have to get hospice in here. I cannot do this alone. You need hospice. That's my third point.
No. And also don't forget, especially with all of the end of life, there's so many amazing elder care lawyers in New Jersey too. They give free consultations. You can call for questions. I've learned most of my information just from their webinars, their seminars, and they're very, very educational.
Yes.
I agree. There's plenty of resources out there, and I highly recommend everyone take some time to join some webinars, just read over some documents so you know everything that's available to you and your family members. And it doesn't seem that we're getting any more questions at the time. So I guess I'm going to go ahead and end it right here. So just one last thank you to all of our speakers and everyone who took the time to listen in today. It's very much appreciated. I hope you guys enjoy the rest of your afternoon and enjoy your days.
Yes. Thank you.
Thank you. Do the same. Bye. And thank you, Adrian.
Yes, thank you, Adrian.
Bye, guys. Thank you.